Friends, very good afternoon to all of you. And we have a very interesting session ahead with the galaxy of speakers. And along with me, chairing the session is Dr. Tangavel, past president of Tamil Nadu Ophthalmic Association. He doesn't require any introduction. And also Dr. Praveen Kumar from Sivagasi. He is a very dynamic anterior segment surgeon. My student as well, correct. And we'll go on to the first speaker and on different situations as far as the phacoemulsification is concerned. Is Dr. Ramurthy around? Yes. Dr. Ramurthy is there and he's going to talk to us on small pupils. Just now in the other session we are talking about the small pupils, and you have none other than Dr. Ramurthy, a stalwart from Coimbatore Eye Foundation, and he's going to talk to us on small pupils in phaco for 8 minutes. Thanks.
Thank you, Mohan. I'll be speaking on phaco in small people. It's just a string of videos that I'm going to show. Very often when I'm faced with a situation like this, there are no specific maneuvers that I need. It's not moving. Yeah. So you see, it's about a 4 millimeter pupil. I always stain these capsules. I always differentiate between a small pupil phacoemulsification and a small rhexis phacoemulsification. If I'm able to get a rhexis about 4.5 millimeters, as in this case, where the rhexis is running just under the pupillary margin, then I think I'm able to manage without any devices at all. This video is running at 2x speed. And as you can see, I have removed the capsule and then the loose cortex and the epinucleus. I create a small trench. Please note that almost all the maneuvers are happening within the 3.5 to 4 millimeters that is seen. It's a direct chop that I do, a small trench which gives me access to the meat of the nucleus. Bury just using longitudinal phaco, bury into the core of the nucleus, and then do a more like a vertical chop. And then basically the number of chops I do is depending on the hardness of the nucleus. Please understand that all this is happening within the confines of the rhexis, that is the pupillary area that is seen. That's dispersive viscoelastic coating. And then there is some amount of HPMC that's also injected, because I want the phacoemulsification itself to be happening in a lake of HPMC. And here again, it's nucleus, the phaco tip as such remains fairly stationary. I just use a second instrument to position the nucleus fragments. And then, because of the particular settings, which is moderate, I use an intraocular pressure of just 30. You see the nucleus fragments literally flowing in. It's always a good idea to keep away from the pupillary margin, because once you have caught hold of the pupil, then subsequently the surgery becomes a little more difficult. It's a bimanual eye irrigation aspiration that I always favor. And here you can see, even in this situation, hydro-assisted implantation of the intraocular lens is possible. It's always a good idea to get the lens inside the bag in one go, because if it goes into the sulcus in a small pupil situation, it becomes a little more difficult to maneuver this case. This is not really a small pupil, but an irregular pupil. You can see there is a iris coloboma there. So it's basically small, in certain aspects quite large, so makes the surgery a little difficult. So this is something that I favor quite a lot, of using iris hooks. Extremely cost effective, just requires a couple of minutes for putting them in. And you can see that these lenses, this has been placed in the 3 quadrants. In the area the coloboma is not needed. There could also be zonular deficiency, lens deficiency in those areas. The phaco chop itself is carried out very carefully, so that the lateral separation is something that stresses the zonular apparatus. And you can see that that's being done. And the presence of the iris hooks, which essentially have been placed in the quadrants where it is necessary, gives me excellent visualization right through the procedure. And basically, you place the iris hooks after filling the chamber with viscoelastic, as well as injecting a little bit of viscoelastic under the iris, so that there is enough space for going in. And the small incisions are quite small, usually just about 0.6 millimeters in size. And then they are directed towards the iris margins, so that the placement of these iris is quite simple and easy. and that's the rest of the phacoemulsification being carried out. Once you have this in place, then most often, almost all maneuvers are quite easy to perform, and good visualization is there. And whenever have a complex situation like even a PCR, sometimes it might be a good idea to place these iris hooks because it significantly enhances the quality of visualization that's there. That's the intraocular lens being also placed. Before the removal of the viscoelastic, it's a good idea to loosen up these iris hooks and then remove them, and then go ahead and remove the viscoelastic, and the case is completed in a very controlled manner. And sometimes in a situation like this where you initially think there is good pupillary dilatation, especially in an IFIS case, the pupil can come down. Then even in this situation, you can go ahead and place the iris hooks. But you have to be cognizant of the fact there is an open capsular rhexis margin, and you should not capture the margin in the capsular rhexis. But then it's something that's doable, and you can go ahead and complete the surgery with greater visualization using the same iris hooks as we saw. There can be pupillary expanders that are used. A BX ring is something that's commonly available. Again, a reasonably cost-effective device. And this is basically the Suven Bhattacharya, our own, is responsible for this innovation. It comes with six scrolls as well as 6 notches. The notches go underneath the iris margin, capturing them. 3 of the scrolls remain anteriorly, 3 of the scrolls remain go posteriorly, and it gives something like a hexagonal shape, and that's the reason it's called a BX ring, Bhattacharya hexagonal segment. And once you get this, you can see that there is excellent visualization, and you can carry out all the maneuvers, including the introduction of the intraocular lens. And removal of this is again very easy. It can come out even through you usually use a 23 gauge grasping instrument, which comes along with the Bhattacharya ring, and then you can it can even come out through a 1 millimeter incision, and it's extremely shallow as far as its outline is concerned. The Malugin ring, which has been there for a much longer time, is slightly thicker in its profile, but at the same time, especially in IFIS cases, this is a preferred device. And as you can see, as you introduce this, both the leading as well as the side profiles can capture the pupillary margin, and it's only the subincisional area where you need to maneuver it in. Usually what I use is a Sinskey hook to position it exactly. Then you can also rotate it in a direction so that what you get is a more circular circular profile of the pupil. Then complete all your maneuvers and then bring the device out. Here again, it's a good idea to bring the device out while the chamber is still filled with viscoelastic. Essentially, the same instrument which was used to inject the instrument. I think I still have 1 minute. The device inside is used to take it out. There are small micro ruptures of the pupil. That's the pupillary margin. That's why you see those small bleeds, but then it can be easily washed out. What about if you have to do a laser refractive cataract surgery in a situation where we have a small pupil? As you can see over here, it's just about 3 millimeters, 3.5 to 4 millimeters in size, but usually it's what happens is, because we aim at a 5 millimeter pupil rhexis margin, it shows that the rhexis is too large. So we go out to a mode called the pupil maximized, where immediately it drops down to 3.8 because the pupil size is about 4.8, and by default the rhexis is set about 0.5 millimeters on either direction. So in this, you manually adjust the detents in such a way that you maximize the size of the pupillary opening that you create. Here essentially I've gone on to 4.4 millimeters. I still feel a slight amount of space is available. I'm constantly looking at the profiles, both the coronal and the sagittal, making sure that I get the maximal amount of rhexis margin, and I'm able to enlarge it up almost up to 4.6 millimeters. And then subsequently I go on to that's the laser firing. It just takes about 1.4 seconds. That's the rhexis which is being separated. Of course, you can go ahead and, in case you want, you can go ahead and introduce the iris hooks even in this situation. That's not really necessary. Here what I'm doing is, because of the limited visualization, I do a direct with the stop and
Can
chop
you just
technique.
wind up, Ramurthy?
Once it's basically divided into two segments, I go ahead and using the right parameters, remove the nucleus fragments, and introduce the intraocular lens again in one go. Suffice it to say that using the right techniques and technology, most of these cases can be handled quite adequately. Thank you so much.
Thank you, Dr. Ramurthy, for the wonderful talk. And we go on to the next speaker. We'll have a discussion at the end of the session if we have time. And I request Dr. Praveen to call the next speaker.
Request Dr. Sujata Mohan ma'am from Rajan Eye Care to give speech.
Can I have the speakers in the first row, please? Special sofa has been arranged. Leaving, is it? Okay. Okay. Thank you, Ramurthy. Speakers like, yeah.
Good afternoon, everybody. At the outset, I'd like to
Vanaja.
thank the organizers for giving me this talk. My talk is on phaco and compromised corneas. So what is a compromised cornea? Any cornea which is unhealthy. It could be local causes such as pterygium, spheroidal degeneration, keratoconus, patients with endothelial disease, systemic diseases that can affect the cornea, post-refractive surgery, and a previously operated eye. So the most important thing is documentation of the corneal pathology. Do a specular microscopy. Please explain to the patient what the problem is. Do a systemic disease evaluation, which includes diabetes, collagen muscular disorder. Look at the pachymetry and the corneal biomechanics and topography in patients with keratoconus and PMD. So risk involved in compromised corneas has to be explained to the patient. The difficulties that you can face has to be documented, and the prognosis for the outcome also should be discussed. Compromised corneas, epithelial problems could be EBMD or dry eye or post-herpetic corneas. Patient can have Bell's palsy with exposure keratitis, post-RK or post-PK corneas, Fuchs dystrophy, and keratoconus. So it's important if you're dealing with a viral keratitis patient, there should not be any active ulceration, but you have to tell the patient that the chance of reactivation is there once we start using steroids. Bell's palsy is another problem which we have to treat. So after the procedure, you have to do a tarsography so that the exposure does not continue. First, repair the ocular surface and then do a tarsography. And lid taping also has to be advised. In corneal scars, the problem is how do we do a keratometry? Either you can take the keratometry from the other eye, or you can do a DALC, and then after 3 to 6 months, once the cornea stabilizes, you can go for a phaco surgery. So post-PK cataract surgery, you can see the first eye had the picture on the top has about 14 diopters of astigmatism, and after suture removal, we got about 7 diopters of astigmatism, for which we used a customized intraocular lens. So compromise to the corneal surface, such as exposure keratitis, limbal stem cell deficiency, topical drug toxicity due to AGM, contact lens abuse, immune ulcers, infective keratitis, neurotrophic keratopathy, and also should be dealt with. And most important thing is look for corneal anesthesia in these patients. Other considerations are whether you're going to do a corneal tunnel or a scleral incision, whether you're going to do a superficial keratectomy in patients with EBMD and Salzmann nodular degeneration, management of pterygium, whether you're going to do it first or in concurrence with cataract surgery. Again, this is a big topic, but I prefer to do the pterygium first, wait for 6 weeks, and then do the cataract. Anterior corneal dystrophies, you may need to do a PTK or LK. Avoid multifocals or premium lenses in these patients and use fortified BSS. Systemic problems such as rheumatology, control of systemic parameters before surgery is very important. Protect the ocular surface. These patients may need long-term steroids. Use of NSAIDs can cause corneal melt, and so has to be followed up very closely. So these type of corneas, definitely you have to treat the ocular surface before taking up the patient for surgery. In the case of endothelial disease, advanced endothelial disease, you can go for direct combined procedure. But in patients who have a reasonably good cornea with endothelial cell density of more than 1,000 cells, you can wait for some time. You can do a cataract surgery and then probably may need a DSEC or a DMEC later, at a later date. So if you're doing a phaco in a patient who has some amount of corneal problem, but not enough to take him out for combined procedure, use a cold phaco technique, reduce your phaco energy, use a phaco chop technique, do eat the back phaco, and most importantly, use a high density viscoelastic and a soft shell technique. So this is a patient who has, you can see, a bullous keratopathy. You can see that the epithelium is loose and it's come out very nicely, just like a capsulorhexis. And now in this patient, the plan is to do a phaco along with a DSEC. So the phaco is done in a very routine manner in this patient. We really don't have to worry too much about the endothelium because we are going to replace it. So the care has to be taken to avoid any posterior segment problems like a nucleus drop or a PCR. And try to make the rexes a little bit smaller than you would normally do because you don't want the lens to pop out and touch the graft. So it's better to keep the lens in position, and that's possible only if you do have a smaller graft. And the phaco can be a cold, whatever technique you're comfortable with, the same technique you can use, and just make sure that, there is absolutely no complication in these patients. So the phaco is done. This is about a grade 2 nucleus and followed by an IA. I prefer coaxial IA. There are a lot of people who do bimanual IA. So whatever you're comfortable with, and then you put the intraocular lens. So at this stage, it's important you go under the lens and remove the viscoelastic first before you constrict the pupil. So you do need some viscoelastic in the anterior chamber. Because what you're going to do is you need to strip the desciments. You can see that I'm using a reverse Sinsky to strip the desciments. You can get a nice red glow if you have the pupils well dilated. But you have to remove the viscoelastic from under the lens before you do this. And then once you've got a nice descementorhexis, in this patient, it has come out like a clean sheet. In patients who have scars, you may have a little bits of desciments remaining. And once it is done, you again do a cortic. It's not now. It's you completely wash out the viscoelastic, constrict the pupil. That's very important because you don't want the graft to touch it. Now I'm doing a small PI with a vitrector, peripheral iodotomy with vitrector, so that when we inject air for a DSEC, then it will not cause a pupillary block. So these patients, now I'm using a glide to insert the graft which has already been prepared. So this, you can see that the top portion of the graft is being removed, only the bottom portion, the with stroma, that is endothelium with stroma, is inserted. This is called the push-through technique. There are various methods that you can do, whatever you're comfortable with, and this is what I'm most comfortable with. And then you inject a saline to unfold the graft. And you can center it either by tapping on the graft, or you can use a reverse Sinsky to gently position the graft. And you can apply a single suture so that the air does not escape. So initially you give a nice tight air fill, and then you can reduce it by the time you finish the case. So this is a post-op of the patient. This is again a patient with the phaco DSEC. I'm just going ahead. So these are some of the patients who have had DSEC done. I have one more minute to go. So the next case is, what are we going to do with stromal dystrophy, spheroidal degeneration, and keratoconus? These patients, it's better to do a DALC first, and then follow it up with a phaco. So in this patient, the patient had the DALC done, and she developed cataract over a period of time. And these patients, all sutures have to come out. And once you've adjusted all the astigmatism and so all sutures are out, you can go ahead with a surgery for cataract. And based on what type of astigmatism you have, you can order special lenses. These patients, this patient has a small pupils. I'm using an iris hook. So the idea here is we have to keep the endothelium very clear. So you use a good high density viscoelastic, which will protect the endothelium, use a soft shell technique, and do the cataract in a regular way. So other problems are RK, PRK, and LASIK. Also patients with intacts and other conditions like chronic dry eye disease, MGD, EBMD, and pterygium. So treat the ocular surface, counsel the patient, post-keratoplasty, all sutures to be removed, and do combined procedures whenever required. Thank you.
That was a fantastic talk, ma'am. Next, I would call upon Dr. Mohan Rajan sir to speak on phaco in torn rexes.
Sorry. Thank you, Praveen and Tangavel sir, and thank you to NOA for this wonderful opportunity. I'm going to just modify my talk and telling you about the Rex's tips and tricks in the next 8 minutes. These are my financial interests. As you know, continuous curvilinear capsulotomy, first described by Gimbel and Nguyen in 1985. It's important that you visualize clearly, have a good red glow, adjust the microscope, IPD, illumination, and fine focus, replace the gel. Needle rexes, as you can see here, this is a needle rexes, just to show you how do you do a needle rexes. Always make sure that you go in a, the centripetal fashion, and the shearing technique, and making sure that the anterior chamber is deep. Just to show you that this I have called it as pincho rexis. Just pinch the anterior capsule, and with the rotator forceps you can turn it around, and you can either do through the side port or the main port. I usually normally use the main port because I use viscoelastic like Hyalon always for all my patients, and it makes our life very simple. And again, this is just to show you that how you just pinch the anterior capsule and turn it around in a centripetal fashion. Always every 3 o'clock hours you need to regrasp the rexis and go in a circular fashion as well. Just to show you this PPC, making sure that your rexis is not very big, not very small. If it's not going to be very small, it's going to be difficult for you. If it's very big, it's very difficult to capture the haptic, optic capture when you have a PCR in a pupil. Always rexis under the pupil is very, very important, especially when you could avoid, especially when small pupils. Also, trypan blue is very important because you need to visualize the rexis even if the pupil becomes small. So the size of the rexis actually matters, as Ramurthy was mentioning, that not the size of the pupil, because you know exactly where your size, where your rexis margin is if you have trypan blue. Just to show you that rexis margin going underneath, following that margin of the rexis, and going underneath and making sure that you follow the margin very, very, very carefully. And you can see that the pupil, this is a patient who had an IFIS syndrome as well. Again, another patient with the fibrotic anterior syndrome, anterior capsule, and go all around the fibrosis. So go all around the thing. With the femto, I have an advantage. I can sing, but here is the manual. I'm just centering. You can see the go all around the fibrotic, so you can include that fibrotic. So you can see that this is the intermittent cataract. These are the main challenges as far as rexis is concerned, and the toned rexis, the intermittent white cataracts, the type 1, the mature white cataracts, and the hypermature white cataracts. The type 1 is the very dangerous as far as Argentina. Flag sign, I have described this punctorexis, which are published. We have won the AOS award, APCRS award, and so many things. You can just punch the anterior capsule. You can just go bevel down and punch with the vacuum, and then punch it. And what happens is the punching actually not only punches the anterior capsule, but also debulks, because you're giving a phacoemulsification. It debulks the nucleus as well and decompresses both the anterior and posterior compartments within a millisecond. So you can use a 30 gauge needle. You can see here how I'm aspirating the front compartment. So you can see the liquid cortex, how beautifully it's getting aspirated. Then you can go ahead with the piscine. This works in about 60% of the time in type 1 cataracts, and because you are taking care only of the front compartment, you're not taking care of the posterior compartment, which is again very, very important for you to do that if you want to prevent Argentina flag sign 10 out of 10 times. Or you can use a white cataract femto. I'm using this now regularly for all my patients because this is absolutely a foolproof method. Just to show you that double rexis in a mature cataract, what you do is, if you want to do, always aim for a smaller rexis. If you go for a smaller rexis, if you go for bigger rexis, the problem is you can go to the zonal area and you can lose the rexis, and you can end up, especially when you have a white cataract like this and a harder cataract as well. And if you lose the rexis, it's going to be a double trouble, I would say, or even triple trouble and multiple troubles. You can see here what I'm trying to do is aiming for a smaller rexis. So what I'm doing is, so obviously this small rexis, I'm not be able to tackle such a very brown cataract. So what I'm doing is I'm just debulking the nucleus with a small rexis and going ahead with I'm doing a hydro dissection, making sure that I'm removing the cortex from the posterior aspect of the lens, and then bulking the nucleus, doing some phacoemulsification. Then I'm going ahead, and now what I do is, I know that this rexis is not very big enough for me to do a good phacoemulsification, in the back phacoemulsification, and because without damaging the rexis margin. So I go ahead and do the enlargement of the rexis. So once I debulk, then I enlargement of the rexis. I use the vitreous scissors there and cut not cut horizontally, need to cut a little obliquely, and you can see how I'm enlarging that rexis margin. It's always better to use rotator forceps, you have better control. And once I enlarge the rexis margin, the rest is a very important thing. Escaping rexis, again, this video is not playing anyway. Yeah. You can see here this escaping rexus. Once you escape, see what is happening is the rexus is escaping there. So don't be in a hurry. Come out of the eye, put in some viscoelastic like viscoat, and then try to use a microrexus forceps and try to pull that rexus from the base of the rexus towards the, to pull it towards the center of the pupil, and then you'll be able to do that as well. Again, another patient with the escaping rexus, you can see here, again, it is in the periphery, and it works very well. Again, we're putting a viscoelastic. The viscoat actually flattens. So viscoat is actually made with the Alcon company, but even the Aurolab is now come out with that, and it's called the Aurocoat. No, it's Aurocoat, if I'm right. Aurocoat, even the Apasami. This Argentina flag sign, you can see here, this Argentina flag sign. As soon as it touched the anterior capsule, it's going into the periphery. It's a type 1 intermediate cataract. Once you have an Argentina flag sign, what happens? It's very difficult because this Argentina flag sign, the rexus can wrap around the equator and go into the posterior thing, and you can lose the nucleus as soon as you put the phaco probe. So once you have an Argentina flag sign, this patient is actually a former union minister. He came to me, and they commit, as you know, they commit a lot of sins and come to you. And then this physician was watching through the side tube, and just then I returned from Brazil and was asking me what this. I said, this is a very beautiful technique I learned from Brazil. This is Argentina. So it's called Argentina flag sign technique. So I converted that rexus into a semicircular rexus. You can see here, and another cut I made and converted the rexus into a semicircular rexus, and then convert this side as well. So you have a fairly good rexus on both sides, but there is an extension at 6 o'clock, there's an extension at 12 o'clock. The extension at 12 o'clock is not very bothersome, but the extension at 6 o'clock is likely to extend. So what is important is, you need to make this is a grade 2 cataract. If it's a grade 4, grade 5 cataract, I would suggest, unless you have a good experience, otherwise you convert into a phacoemulsification. So into an ECCM, or an SICS. You can see here what I'm trying to do is a vertical chop technique. There's no stress on the bag at all. Vertical chopping, I'm using my sharp chopper, the Mohan Rajan chopper, made by Apasami Associates. I don't have any financial interest in that. But it opens up the posterior nuclear plate without any stress on the capsular bag. And I bring the nucleus up. I don't mind losing some endothelial cells, but I don't want to lose that, the rexus going into the posterior, wrapping around and going into the, and losing the nucleus into the thing. Then every time you come out of the eye, you need to make sure that you inject viscoelastic, preferably Hyalon, that will expand the bag. I can see here. And this patient wanted actually a multifocal lens, but I put only a unifocal, and the patient was doing very well. Absolutely no problem. Again, you can see another patient. I did in the initial phase of my punctorexis. I'll take another 30 seconds or 1 minute for this thing. And you can see here because I went tangential. You need to go vertically down in punctorexis. If you go tangentially, you will end up in Argentina flag sign like this. Again, the same technique. Again, if you have a rexus which is going to the periphery, then what you call the little rescue, as described by Brian Little, what you do is go to the periphery. Once it goes to the periphery, if you try to pull it in the same direction, it will go further to the periphery. You don't want to do that. So you flatten that with the viscoelastic, preferably viscoat, and then pull it in the same direction. Pull it in the same direction. As I'm pulling it to the same direction as the rexus. I see pulling it to the same direction, and once you pull it in the same direction, the rexus will start coming from the periphery into the center. You can see that once I do that, the rexus is starting to come to the periphery, from the periphery into the center, and which then you can complete the rexus in the usual manner. You can see how beautifully the rexus is coming there, and it's making the life easy for you. And this is again. Be careful, especially when you have a small rexus and a big nucleus, hydro rupture. You can see that hydro rupture can occur, and this is another important thing which you need to be careful. Again, rexus tear during IA, rexus extension, since you don't have time. Just to show you one final message, this is a patient with a hard brown cataract. I lost a rexus. I converted this into a patient because this patient had also, microophthalmus and coloboma as well. The take-home message is gentle or no hydrodissection, direct chop technique or the vertical chop, iris plane or anterior chamber phaco, making sure that you have good condylar endothelial protection, inject viscoelastic every time into the anterior chamber through the side port when you come out of the eye, convert to ECG or SSCs in case of brown, black cataracts. Thank you very much, and for the wonderful opportunity and the patient attention as well.
Thank you, Doctor. Thank you, Dr. Mohan. Next, I invite Dr. Vanuja Vaidyanathan to talk on Phaco in white and brown black cataracts.
Dr. Vanaja doesn't require any introduction. She's one of the top surgeons from Pondicherry, very, very good surgeon, and Jyoti Eye Care Hospital. And I had the wonderful opportunity of inaugurating the hospital a long time back, 20 years back, if I remember right. And Vanaja is also being trained by us
Yes.
at Rajan Eye Care. Thank you, Vanaja.
I was supposed
I'm
to
very,
tell
I'm
that,
so
sir,
proud
you
of you.
told it.
Thank you.
So, warm greetings to all, respects to my teacher, Dr. Mohan Rajan, and all the other senior ophthalmologists and ophthalmic fraternity. It gives me immense pleasure to be here, to be talking on my topic, Phaco in white and black cataracts. Can you full screen? Thanks to T&OA for giving me this wonderful opportunity. All these cataracts are dangerous, so who will bell these cats? It's a nightmare to any surgeon. Preoperative considerations are to be taken in. Older the patient, greater the grade of cataract, lesser the endothelial count, and association of comorbidities like pseudoexfoliation, small pupil, zonular weakness, extremes of refractive errors, and associated raised pressure, be it lens-induced or primary. All of these are factors which will have to make you wonder whether Phaco is possible and safe, or whether we have to plan for other methods. So intraoperative considerations include some of the patients having kyphosis, scoliosis, or head nodding like this patient here with a mature cataract, and also nystagmus, etc. Positioning the patient is important. You need to have a good team to help you carry out the cataract surgery itself. A good microscope, phaco machine, and like my previous speaker said, femto laser, which gives a pre-cut to all these dense cataracts, would be very beneficial. And all steps need to be very carefully gauged. Error-free surgery is important, because otherwise completing a phaco in a mature or hypermature cataract would be a difficult thing. Already Dr. Mohan Rajan has talked about how rexes can be well planned in these cataracts. White cataract with not much of intumescence, just you need to stain and carry on, and it is going to be done. I don't know why that video is not running. Whereas if it's an intumescent cataract, I prefer to go through the side port. I use cohesive viscoelastic, and I go through the side port. I use the micro-rexes for the capsulorhexis, because the micro-rexes through the side port will keep the chamber stable for a longer time compared to going through the main port. So that's the different point I thought I would bring about here. So going through and see here the rexes, I keep it small, so it's not as big as I wanted it to be. So I make a nick and I'm extending through the side port. So side port is one trick which I wanted to quote here, because through side port, your chamber remains stable for a longer time. It's not playing. A new phaco tip, or relatively new phaco tip, is important. 2.8 mm tip, because not a 2.2, because clogging is one very important factor you have to keep in mind. It keeps getting clogged otherwise. A new BSS bottle or maximum bottle height, when it is not IOP based machine, is important. Mini hydro or small bouts of hydro at different quadrants instead of one shot of fluid. In the previous video, you saw how it can lead to blowout if you just inject at one quadrant. And viscoat usage and frequent filling of chamber with viscoelastics is also equally important to protect the endothelium. And keeping antivitrectomy ready, and also using, because you are using very high parameters, safeguarding the wound is very, very important. And we should not forget to lower parameters in the end, because towards the end is where generally people tend to have, I'm trying to fast forward it. Can I not fast forward it? So So it's towards the end that you have to be very careful generally, because that's where you can have problems. Machines like Centurion, where the IOP, it's an IOP-based fluidics, at very high vacuum, improved holding force, chopping, and stability of the chamber can be obtained. Active fluidics will maintain excellent chamber stability and pressure stability. So balanced energy optimizes torsional phaco with innovative software and instrumentation. I'm sorry, one video only is running all the time, the other video is stopping. I'm not able to, have control on the video here. The second one, can you just fast forward a little bit towards the end? The first video has stopped playing. Can you play it? So these are cases where very hard brown cataracts in Centurion machine, we can handle very nicely at even a intraocular pressure of 50 or 60, whereas with the highest bottle height, it goes to 80, 90, which is not very good in some of the situations where zonules are weak or in a case of glaucoma, etc. So whether it is traditional, infinity or Centurion, the outcome is important, and I myself personally, having used all these machines, I know the outcomes are best with IOP based machines. A good machine is important for these cataracts. Next. I'm not able to, yes. Can I handle forward, fast forward? Because it's a big video, I cannot. So this is actually just like Dr. Ramamurthy had shown, with associated comorbidities like small pupil, zonular weakness. What are the ways you can manage? So I wanted to show this. Yes. So you can either do a stretch or use iris hooks. Can you just fast forward? One more minute only. Use Malujan ring. In this case, I'm using both Malujan ring, and then in the middle, just little more fast forward. In the middle, when I have a zonular dialysis of about a quadrant, I use an endocapsular ring and complete the case. So after the endocapsular ring is inserted, the cortical wash also becomes easier at the zonular dialysis site itself. So కొంచెం fast forward பண்ணிட்டேன். So in this case, I explained the Malujan ring in toto. That is, in the subsequent case, the Malujan ring, while it's getting removed, it gets entangled in the bag, and then I have to cut and take out. For want of time, I'll just skip this video. So next. Yeah. So in conclusion, guarded prognosis has to be given to all mature cataracts, because you may not be very sure of placing the right type of lens. You may have promised even premium lenses, but you have to make the point very clear that only if surgery goes on well, you can place a multifocal or a premium lens. And again, special consent has to be obtained. B-scan is important. You can use even mannitol preoperatively to have optimum result, especially if the IOP is slightly on the higher side or if there's a lens-induced glaucoma. Preoperative dilatation has to be adequate. Intracameral phenocaine has become a very important tool in our practice. Anesthesia has to be peribulbar. Even in the best of hands, it's preferable to have peribulbar anesthesia when a cataract like this is there. Viscoat or cohesive viscoelastics are important, as I mentioned. Hooks, Malujan rings, and then keeping good tip, high bottle height, and keeping antivitrectomy ready. here I'm showing how a vertical chop, when there is a zonular weakness or a capsule not very good, you can bring it to iris plane and do a peripheral chop, a direct chop, which can be a peripheral chop. Whereas if there is the second video is that of a vertical chop, where you have a compromised endothelium, you do a vertical chop. A combination can be done when there are both these odds. And frequent filling of the chamber with viscoelastic is important, safeguarding the wound. And if you have a problem, do not hesitate to suture. And conversion to SICS is also important when there is a problem. And keeping all types of lenses available is important. So if techniques and technologies are properly understood and followed, belling these cataracts is a cakewalk. So thank you all for the patient listening, and sorry for the interruption in the videos.
Thank you, Vanada, for the wonderful videos, wonderful talk. I know it's a very difficult scenario to do phaco in black-brown cataracts, and you did it so well. And we go on to the next speaker, who, in my opinion, the highest volume surgeon in the entire world, cataract surgeon, and Dr. Haripriya Arvind from Aravind Eye Hospital, Chennai, and she's going to talk to us on a very important topic, and phaco in subluxated cataracts. Over to Haripriya.
It's okay. It's fine. Thank you, sir, for your kind words. I'm not sure that is true, but makes one feel good for sure. So I'll be talking on subluxated cataracts. So we have to consider what are the indications for surgery. Not every patient who comes to our doorstep with lens subluxation needs surgery. Either if the patient has a cataract which causes the vision to drop, or if there's double vision, or the lens has moved either into the anterior chamber or into the vitreous, then surgery is indicated. So on examination pre-op, we have to look to a thorough investigation from the ocular point of view and the systemic, especially if it's an ectopia lentis patient, they may have coexisting morbidity. Patients with Marfan's may have some cardiac illness, so you have to have a good evaluation. The lens, we have to look for, was it a subtle phacodonosis or is it more segmental? Usually segmental is more seen in traumatic if you don't have any phacodonosis, and these patients are easier to handle. Whereas if you have a phacodonosis overall with diffuse weakness, in cases like soda exfoliation or hypermature lenses, they are more difficult to handle. Again, the patients who are segmental, like in ectopia lentis, Marfan's, you'll see only in one quadrant, but other areas as well, the zonules will be weak. So it's important for us to know the etiology as well. And also look at whether there's any vitreous is there. All of that has to be also evaluated to plan for the technique, where the incision has to be placed, etc. So capsular rhexis is very critical because that is what enables us to use the hooks or the CTR and do the phacoemulsification per se. So I prefer using a very good viscoelastic. So I use a dispersive viscoelastic and make sure the area where there is no zonular support is well covered. I start the rhexis away from the area of subluxation because there you have the counter traction and one can make a larger rhexis there. So consciously you make it larger there, and one will have to make it smaller at the site where the zonular lysis is there. Otherwise the rhexis will run to the periphery. So try to have your incision small. If one is doing SICs as well, don't extend the wound at this point. Just enter 2.8, come out, do the rhexis, and then continue with the subsequent steps. So capsular tension rings are very useful because they help to keep the bag open, distance the bag well. So these rings come in different sizes. Commonly what is used is the 11-13 ring, which means if the ring is compressed, that is, if it is within the bag, it is 11 millimeters. Outside the eye, it is 13 millimeters. In very small lenses, like microspherophakic lenses in children, we can use the 10-12. And large eyes, like in myopes or megalocorneas, we can use the 12-14. But in your OT, you can always have a 11-13. That should work for 90-95% of your cases. So again, the other important aid device, which I think everyone has to have in the OT, is to have these hooks. So I use the regular iris hooks on the capsule as well, which is the Grieshaber hooks, not the thick ones, but the Grieshaber are comparatively thinner. And this to me works very well to give stability to the capsular bag during the phaco and while placing the lens as well. So so in this patient, as you can see, the side port is made on the left side, so the lens can fall back, you can push it back, and also seal the area of subluxation with viscoat. Then the side port is used to make the rexus. This way again, you reduce the viscoelastic which will escape the eye, start the rexus away from the area of subluxation. You'll have to make it not too large, again, because of risk of extension, but just right sized. And remember that once the bag is centered, the rexus also has to center. So you have to have it a little more eccentric, not central to the pupil, but central to the lens. So the hook, like I said, is made, the one which is used is the Greisch-Haber hooks. The side port could be even 0.5 millimeter, 15-degree knife. And I would place one hook for every 1.5 hour clock hour of subluxation. So you will stabilize it. So right after the rexus, I'd like to place it because that is when your visibility is the best before your hydrodissection. Once the capsular bag is stabilized, then the hydrodissection is done. So I do this before placing the CTR if I plan to place a CTR. So why? Because then now your cortex becomes loose. It becomes easier for us to aspirate the cortex if we do the hydrodissection before placing the CTR. The CTR is placed through the side port. You ensure the leading eyelid goes in the back, and the trailing eyelid also has to go into the back, which is probably of a bigger challenge. So to ensure that this happens, you will have to take it in. So you make your hook side port is just 0.5, but at least 1.5 is good for your CTR insertion side port, I would think. Take your McPherson's forceps kind of as close as possible. Second, non-dominant hand, use a Sinski, which is over the edge of the CTR outside. So you can use that to flex it and release it in the bag, or you can also use the Sinski to hold the eyelid and release it. But sometimes it may get stuck, so one can consider, if it does get stuck, tap it on the right side with a spatula and push it back in, could be an option. In severe subluxations, we can have a modification of a modified CTR, which has an additional loop, either 1 or 2 loops, and this will give stability to the capsular bag. The Cioni ring is basically used in the capsular bag after it has been looped with a suture. So the suture is pre-placed, the ring is placed in the bag, and then the loop is then fixed to the sclera. This way the capsular bag, the ring, and the IOL will be centered. This also gives long-term IOL stability. So this is a patient with a gross subluxation. So like I said, a capsular rexus is done. It's very important to take time, use the forceps, because the steatomes may not work here. So always use the forceps when dealing with patients with subluxation. Again, you have to invest in a good viscoelastic because you want to keep the vitreous at bay. If there is vitreous when you start off, do minimal vitrectomy in the anterior chamber. Again, use a good dispersive, seal it, and then continue with your rexus. As you can see, the lens is tilted, so I'm not able to hook it. So I'm using a spatula in the dominant hand, lifting the rexus. And now, because it's been lifted, the hook is, you can then place it comfortably to hold the capsular bag. So stabilize it, and as you can see, this actually makes the lens look very stable. So these hooks are very useful to stabilize the bag. I would never go in and place a CTR directly. So my only take-home message is subluxation. To me, if you can just start using hooks, you'll find your surgical technique is much, much easier. So good hydrodissection. I haven't used a CTR in this case. I'm doing a phacoemulsification. It's a soft lens using a horizontal chop technique, blunt tip. IOP is 40 here. So my settings are almost the same. I don't change much. Go a little lesser with vacuum and flow rate than I would normally. And try to ensure that you are not putting too much of force on the area of subluxation, because you don't want that part. We don't have a CTR yet, so the capsular bag may collapse. So you want to ensure that your phaco is away from that area of subluxation, more in the safe zone. And very stable chamber is important. So step down your parameters, very stable chamber. So irrigation aspiration in this case would be easier than the normal patients with subluxation because the CTR has not been placed yet. However, the bag again is open. You can have a collapse of the equator. So one has to be aware of it. So very gentle. You can do a hydro before you do the INA. I'll just take a few more seconds, sir. I'm not able to move it forward too. Yeah. So I'm just using a Cioni ring here. So it has a thread which is already placed on the loop. It's placed in the capsular bag. When introducing a 2 point, it goes in through a 2.8 incision. Ensure the convex side of the loop enters. So when you're introducing it, if you want to know which side to, don't let it, open. The eyelid shouldn't enter, but the convex side of the CONE has to enter. It's then dialed to the area with maximum subluxation. A Hoffman's pocket is created at the side of maximum subluxation. So the knot can then lie in the pocket. You don't have to actually make a flap. So this pocket works well. I like to make a conjunctival dissection before I do the pocket. So I am just doing a 27 gauge needle to dock the suture needle out through the Hoffman's pocket. So both of these suture needles are then brought out through the pocket. So basically, the suture has already been looped on the COD ring before it's introduced, and the suture is now brought out through that pocket. So then, before tying it through the pocket, the two suture ends are brought out and the knot is tied together, having an eye on the centration of the bag. So once this knot is being tied, ensure you're not tying it too tightly, because you don't want to have the bag pushed to one side. So you have an eye on the rexus margin and then tighten it and push the knot into the pocket. And before I place the lens, I like to always go back and place the hooks. Again, because you don't put too much of pressure on the bag, so I go back, place the hooks. So when dialing, you're trying to keep the zonular stress as less as possible. I'm placing a 3-piece lens here. In this case, the 3-piece is better because in case you have a decentration later on, the same lens, you could either do iris fixation or a sleidal fixation if required. Post-operatively, these patients have to be seen for long. So this is a patient who had a single loop. Some of them may need a double loop as well if they have a lot of subluxation. So post-operatively, please follow them up for uveitis, macular edema, glaucoma, raised IOP. And most important, these bags are weak. So if there are progressive zonal loss over the course of times, they may dislocate. So follow-up would be important. Thank you, sir.
Next, I would like to call upon Dr. Lalit to speak about phaco in extreme eyes.
Lalit, a very, very busy practitioner, has got number of centers in Chennai, and he is a role model for everybody. He is an example of how a very good group practice can do. Over to Lalit.
Thank you for the kind words, sir. In the first place, I'd like to thank TNOA for giving me this opportunity. My talk to you is about phaco in extreme axial lens. So what are the challenges which we face in patients who are myopic or who have large eyes? One is biometry. The second thing is these patients are predisposed to retinal detachment because they are myopes. There are high chance of retinal detachment. There is increased depth of the anterior chamber during surgery, and it can also lead to lens iris diaphragm retropulsion syndrome. I'll just talk to you about it a little later. The iris can be a little floppy and there can be iris prolapse. You must have noticed this in most of the myopic patients which we operate. There might be pupillary constriction. This especially happens after you remove the nucleus and the pupil comes down, and just before the cortical aspiration or just before the nucleus IOL insertion. And there is pain on entering the anterior chamber, and this happens due to sudden deepening of the anterior chamber, which causes a little bit of ciliary body pull, which causes this pain. So these are the usual challenges which we have when we operate on a myopic patient. The challenges which we face in hypermetropic patients are again biometry, definitely. We come across denser cataracts in these patients because nuclear sclerosis happens, and whenever nuclear sclerosis happens, these patients are able to see more clearly. So they don't bother about their cataracts and they come to us in very late stage. These patients have shallow anterior chambers, small eyes, and may also have narrow palpebral fissure. These patients might have corneal endothelial trauma because of shallow chambers. There is a lot of positive pressure during surgery in hypermetropic patients. The pupils might be small, and there is a high chance of choroidal effusion and expulsive hemorrhage in these patients. So how do we manage the patients who have large or myopic eyes? First thing is the biometry. So we have to use the right equipment and the formula. So the Barrett's Universal 2 is the standard formula, but people who don't have access to Barrett's Universal 2 can use the SRK by T for patients who have axial length of more than 22. Very simple to remember. And a good retinal evaluation, and if treatment is required, please go ahead with the retinal treatment. We have to use lower parameters during phaco to reduce the chance of pain and lens iris diaphragm retropulsion syndrome. And we can do this by just mainly lowering the bottle height, or we can operate at lower intraocular pressures by using machines like Centurion or even a Constellation. And we can use phenocaine just in case if the pupil comes down. We can use phenocaine to maintain pupillary dilatation, and it also works beautifully when in patients with iris floppiness, because it makes the iris a little taut and reduces the floppiness of the iris. We can reduce the number of entries and in and out of the eye, and also fill the AC with viscoelastic from the side port. Either you can do it or your assistant can do it. So this reduces the sudden shallowing of the chamber and reduces the chance of retinal detachments also in these patients. Measures in small eyes, again, biometry has to be done using the right equipment. So you can use the Barrett's Universal 2, which works for all spectrum of eyes, whether it's small or large, doesn't matter. Or if you don't have access, then you can use the Hoffer Q for axial lens less than 22 millimeters in size. Lower parameters by using lower the parameters during phaco except bottle height. Here you increase the bottle height a little, so you get a little more space because the chambers are shallow. You can increase the bottle height or increase the IOP in a few machines like Centurion. We can use chondroitin sulfate to coat the endothelium, which in shallow chambers can cause endothelial damage. So you can use chondroitin sulfate. Quick in and quick out surgery, that is very important because sometimes it can lead to a positive pressure from behind. And this is very important. This I do sometimes. Most of these patients might have a PI because of the shallow or narrow angles. You can just inject a little bit of chondroitin sulfate in the area of PI. Now what that does is it reduces the chance of vitreous hydration and aqueous misdirection. So it works very well. It's just like, whenever you have vitreous, you use chondroitin sulfate to block the vitreous. The same thing, same concept can be used here. And in our center, we also use hypotensive anesthesia. I run a multi-specialty hospital where the anesthetist is always around. So we use IV metoprolol. That again reduces the chance of choroidal effusion and expulsive hemorrhage. This is more so whenever we do keratoplasties. This is what we always follow. And we can follow the same concept when we are operating on very small eyes, nano-ophthalmos or micro-ophthalmic eyes. You can actually switch on to hypotensive anesthesia during surgery. So this is a small video of a patient who has a myopic eye. You can see the pupil is nice and well dilated. And I'm just started my capsular rhexis using the cystotome. This is a 5 millimeter rhexis, as you can see here. This is a grade 2 nucleus, not a very dense one. And I'm just doing hydrodissection. And you can see I saw a nice fluid wave, and I'm just going to rotate the nucleus also to make sure that the nucleus is mobile. And then the usual technique. But the only thing which I do differently is whenever I enter the anterior chamber, you can see here, this is what I was talking about. The patient, especially when you're operating under topical anesthesia, this sudden deepening of chamber, and this is what is known as lens iris diaphragm retropulsion syndrome. So basically the iris gets, pushes itself onto the anterior capsule, and the pressure inside the anterior chamber is more than the posterior chamber, and this suddenly deepens the anterior chamber. So you can just use a second instrument, just go below the iris and just lift it up. You can, so I'll be doing it at every stage. Even during cortical aspiration, I do the same thing. This, releases the fluid or the reverse pupillary block, and the patient's pain also comes down, and the chamber is also not very deep. So you can access the nucleus very nicely. You can actually chop it very nicely. And here you can see I'm just going to introduce the foldable lens inside the bag. And even after this, whenever I'm going for the visco aspiration, I do the same thing. You just use your second instrument, whether it is a chopper or a phaco rod, just go below the iris, as you can see here, and lift it up. So that reduces the retropulsion and reduces the pain, especially during topical surgeries. Now, this is one more patient who was a young patient who has a posterior subcapsular cataract, who had an axial length of 19.74 mm. You can see that I'm using sodium hyaluronate here. I've injected into the, I'm trying to deepen the anterior chamber, but the chamber is very, very shallow. I'm using the Utrata to actually try to make a rhexis, but the iris is coming out. So what I do is I use a trocar here. Just maybe around 3 millimeters away from the limbus, you use a trocar and do a limited vitrectomy. You can do a dry vitrectomy. And the end point is you can either use your finger to feel the hardness of the eye, or you can see a few corneal folds here. As you can see here, I'm seeing a few corneal folds on the, and that tells me that this amount of vitrectomy is enough. Now you can see that I've injected the viscoelastic and the chamber deepens very nicely. You have to do a limited vitrectomy. Make sure you don't make the eye very hypotonous, otherwise doing the rhexis will be very difficult and it will try to run out. So minimal vitrectomy, and you can use your left hand, the index finger, to just feel the eye. So this is what I usually do when there's a lot of positive pressure inside the eye. And then the surgery becomes the routine. I've just finished the rhexis using Utrata forceps. And this is a very soft cataract, I just prolapse the nucleus into the anterior chamber and finish the cataract. You can just leave behind the trocar till the end of the surgery. Just in case, if there is any aqueous misdirection, you can again go through the trocar, do a minimal anterior vitrectomy, deepen the chamber and complete the surgery. So that's it. That brings me to the end of my presentation. Thank you so much for the patient hearing. Thank you.
Very nice, very difficult topic, but it did so very well, Lalit, and really hats off to you, showing such difficult cases. And I know hypermetropic small eyes are more difficult, and the lens diaphragm retropulsion syndrome also you showed. So we had a very good session, very good speakers, and really appreciate the efforts by all the speakers, fantastic speakers. Unfortunately, we don't have much time for discussion. I think we have to start the next session. I request all the speakers to come forward for a group photo. Any questions from the audience? One or two quick. Any other sessions here? Next. Sujata, one question for you from Praveen. In case of corneal ulcer, how long you like to wait before you do phaco?
Hello, any infection, it's very critical that you have completely, the infection is gone and you wait for at least 6 weeks post-infection. After the corneal ulcer is healed, you wait for 6 weeks. Because
about
two things,
fungal?
one is if it's viral, it can get reactivated, fungal can get reactivated. So all those things, because post-operatively we are going to put drops. The only thing probably you can do a little bit earlier is bacterial corneal ulcers, which have healed maybe in a month's time, you can do it.
Is 6 weeks good enough, or you want to wait a little longer, 3 months?
We can, actually for fungal, I would like to wait longer because there's a
Excision,
chance of reactivation. But if the patient has mature cataract, it's okay. I think you'll have to be watchful.
Yeah, SEMA will kill me. Thank you.